Okay, this video is about tocolytics. First of all, I'm very sorry because this sheet is preoccupied with lines. Okay, I'm trying to clarify everything with the red color. What is tocolytics? What are tocolytics? They are drugs that are given to give time to steroid to work. Okay, if you remember in the last video, I told you that we give steroid to maturate the lung and to give the steroid the enough time to work between 2 to 7 days. We give tocolytics because tocolytics postpone delivery about 2 to 7 days. How? By stopping uterine contractions or reducing uterine contractions. The first example of tocolytics is beta-agonist. Beta-agonist mechanism of action is decreasing free intracellular calcium. Decreasing free intracellular calcium. Okay. The most famous type of beta-agonist or example of beta-agonist is terbutaline. Terbutaline is given by IV line or subcutaneous or orally. So 3 routes of injection or giving, okay, administration. What are the side effects of tocolytic? Please pay attention because they are important. I just subdivided them into 3 H's and other things. The first H is hypo. Hypo what? Hypotension and hypokalemia. The second H is headache. The third H is hyperglycemia. Okay, hypotension, hypokalemia, headache, hyperglycemia, and tachycardia and pulmonary edema. Okay, so you can just tachycardia, you can put hypercardia instead of them, and then you have 4 H's until now. Okay, and pulmonary edema. So hypokalemia, hypotension, headache, okay, hyperglycemia, and hypercardia or tachycardia and pulmonary edema. And actually pulmonary edema is the most serious among them all. What are the contraindications of beta-agonist? Terbutaline, cardiac disease. Okay, cardiac disease is the most important. DM is also a contraindication. Multiple pregnancy actually is a relative contraindication. Why? Because in multiple pregnancy we have relative overload. Okay, overload in the circulation, and that overload in the circulation will be worsened by giving beta-agonist, so is relatively contraindicated. This is the first tocolytic, beta-agonist. The second one is oxytocin antagonist. Oxytocin antagonist has the same effect, okay, of beta-agonist, but with less side effects. Okay, the same effect with less side effects. So it is more popular and more used in preterm labor. Okay, the most famous example of oxytocin antagonist is atosipan. Okay, so beta agonist, oxytocin antagonist. And third tocolytic is calcium channel blocker. Actually, calcium channel blocker is not exactly a tocolytic. It is not yet licensed to be tocolytic in UK, for example. Okay, it is used in uterotransfer. What do we mean by in uterotransfer? Sometimes the patient is in a preterm labor, so we have to postpone that for a small time, okay, until we transfer her to specialized unit. Sorry, so we give nifedipine, which is the calcium channel blocker, by oral administration, and this is intrautero transfer. Okay, so this is the third tocolytic after beta-agonist and oxytocin antagonist, calcium channel blocker. The fourth one is magnesium sulfate, MgSO4, IV. Is given IV. If you remember, MgSO4 is given in eclampsia, okay, to prevent the happening of eclamptic fit, okay. So this is MgSO4, and also it is used as as a tocolytic by antagonizing intracellular calcium. Okay, beta agonists decrease free intracellular calcium. MgSO4 antagonize intracellular calcium. Okay, the important thing here in MgSO4 that you have to monitor MgSO4. How? By observing urine output, deep tendon reflex, okay, and respiratory rate. You have to monitor the lung, the kidney, the deep tendon reflex, the urine output, the respiratory rate, and deep tendon reflex. If we have any changes in the urine output, in the respiratory rate, or in the deep tendon reflex, then we have to check magnesium. We have to check magnesium to make sure that we have no magnesium toxicity. The fifth tocolytic is non-steroidal anti-inflammatory drugs, and the mechanism of action of non-steroidal anti-inflammatory drugs is prostaglandin inhibitors. So they postpone delivery, and prostaglandin, as you know, predisposed to contractions of the uterus and helping the contraction. So it has nothing to do with intracellular calcium like in beta-agonist and calcium channel blocker and MgSO4. It works by prostaglandin inhibition. The most famous example is indomethacin. What is the most famous example of calcium channel blocker? Nifedipine. Oxytocin antagonist, atosipan. Beta agonist, terbutaline. Non-steroidal inflammatory drug, indomethacin. And actually the side effects of indomethacin are very important to know. Okay, we have a mother side effects and a fetus side effects. Mother side effects like gastric upset and nausea. Okay, this is not the important one. The important one is fetus side effects like oligohydramnios. Actually, that's why we use indomethacin or non-steroidal inflammatory drugs as a treatment of polyhydramnios. Okay, because it causes oligohydramnios. Also, necrotizing enterocolitis is very dangerous and very important to know. Necrotizing enterocolitis, subventricular hemorrhage, okay, and premature closure of ductus arteriosus. Oligohydramnios, necrotizing enterocolitis, subventricular hemorrhage, premature closure of ductus arteriosus. Okay, so from the head down, okay, in the head, subventricular hemorrhage, in the chest, patent ductus arteriosus, in the abdomen, necrotizing enterocolitis or oligohydramnios. Okay, these are the complications of using of indomethacin or non-steroidal inflammatory drugs. Okay, now let's move to the antibiotics. I forgot in the previous video to talk about antibiotics because antibiotics is of course a line, or it is a line of treatment in preterm labor. Okay, we give antibiotic to any woman with preterm labor. We give more than 10 days metronidazole. Okay, 10 days of metronidazole. If she is in active labor, okay, then we give benzyl penicillin. Why? For group B streptococcus. Group B streptococcus, beta benzyl penicillin. Sorry. Okay, and metronidazole for 10 days for other. So antibiotic is an important line of treatment of preterm labor. In addition to other things we have mentioned, hydration, left lateral position, tocolytics, steroids, okay, and the mode of delivery, of course, حكينا vaginal delivery unless we have other indication, obstetric indication of cesarean delivery. Okay, now let's talk about the complications of preterm labor or the outcome on maternal and fetal outcome. Maternal outcome is pulmonary edema from the usage of what? Pulmonary edema. The beta-agonist, terbutaline. Don't you remember? Side effects on the mother is pulmonary edema, the most serious one. Okay, depression also of the mother because of losing her baby. Okay, so we have to plan for another conceiving within 2 weeks. Okay, they should discuss this with the doctor. Cesarean section due to preterm labor or underlying problem that predispose to that problem is also a maternal complication or association problem. Okay, what about fetal problems? There are some problems that are due to the pretermity itself, and other problems due to the usage of drugs, of complication or side effect of drugs. Death, is one of the complications of preterm labor. Hypothermia, why? Because the head circumference of the baby will be large in preterm babies, so they will lose a lot of temperature. So we have to put a hat on preterm labor fetuses. Jaundice, why? Because of lack of liver enzyme or prematurity of liver enzymes. They can't cope with the bilirubin, so the baby will have jaundice. Respiratory distress syndrome, why? Because premature baby, preterm baby will have immaturity of the lung. Now the complications of drugs. What are the complications of endomethacin? Necrotizing enterocolitis, as we said, from the head down. In the head, subventricular hemorrhage. In the chest, patent ductus arteriosus. In the abdomen, necrotizing enterocolitis and oligohydramnios. And also chronic lung disease is a complication. So these are the complications, maternal and fetal, of preterm labor. Now I'm going to talk about cervical incompetence in a few words. Cervical incompetence is a painless dilatation of the cervix. Patient come usually with a history of painless rupture of membrane in the second trimester. How to treat cervical incompetence? You can put a cervical cercalage, which is suture around the external os. When to put cervical cercalage? Between 12 and 14 weeks. When to withdraw it? In the 38 weeks. Or in any case we have induction of labor or preterm labor, we withdraw this cercalage. So normally it is to be put in between 12 to 14 weeks, and sometimes and you have to withdraw it in 38 weeks, and or before an elective cesarean or elective removal of the this cercalage. What to do to prevent preterm labor? Now they are using progesterone. Not enough researches about the usage of progesterone effect on preterm labor, but sometimes it is used. A group education also is used. Thank you very much. This is all about preterm labor. It is helpful. See you in the next video. Thank you very much.